Penicillin. Azithromycin. So ceftriaxone IM or azithromycin PO or both. Ceftriaxone?
Yes.
Or azithromycin or both. That's the same as Herceptin. What about a yellow-green discharge with strawberry spots on the cervix? Trichomoniasis, treated with an antifungal metronidazole. What about chancres that are painless, that progresses to a rash and can further progress to organ issues? Syphilis, treated with penicillin. Gray or white discharge and itching. Chlamydia, treated with doxycycline if they're not pregnant. If they are pregnant, we're back to the azithromycin and amoxicillin options. Or for infants, they get the erythromycin on their eyes as a preventative. This is an STI. Usually the mother is asymptomatic and they are just cultured regularly at this 35 to 38 weeks. Do you remember? Yep, Gram group B strep. And that's penicillin G or ampicillin. And how do we prevent STIs? Abstinence. What are the 2 barrier methods that prevent STIs? Condoms? Diaphragms don't. Vaginal sheaths. Condoms. Other barrier methods like the diaphragm cap, spermicides, IUDs, oral contraceptives do not provide protection against STIs. Yes. It's the internal version of condom. The screening exams for females, we have a breast self-exam, BSE. How often are they doing that? Monthly, 1 week after the period. The mammogram is the screening later, but you're doing your self-breast exams with your fingertips in circular motions all the way up to the corner of the tip into your armpit. You'll feel something. They won't move. So 1 week after menstruation every month. What about a pap smear? 3 years. So starting at age 21, or if they're sexually active before that age, and it's every 3 years. What about males' testicular self-exams? Monthly also. How do they do it? In a warm shower or bath. So they're using the thumb and the forefinger and rolling it during a shower or a warm bath. And every month. So something that was not really touched on in the lecture was about birth plans. So just want to go over what birth plans entail. They don't necessarily have to have all of these, but these questions will be asked by their primary provider, the OBGYN, so that they know what to expect when the time comes. But of course, it's not like a contract, because if something happens, you may not get your birth plan, but we're going to try our best to accommodate you. And so it's going to have information about like what the partner is going to be doing, if they want them there, who else might be in the room, the birth setting. Is it going to be in the hospital, at home, home birth, water birth, what they're doing for labor management, what type of birth, care after birth, and postpartum care. Yeah. Water birth. Yeah, they give birth in the water too. So this was a birth plan that a student last year created, and I thought it was pretty cool. No, it was one of their learning assignments last year, and this was actually a group project, and it was a male and a female that came up with this together. And so they created a birth plan for a mother that is getting an adoptive child. And so you'll see through here that they even included like the family law attorneys and everything to be readily available at the time of birth. Of course, it's not a legally binding contract in and of itself, but showing that they have chosen this person, the adoptive family has chosen that person. The parents agree. Birth father will be there after 30 days. If no action is taken, his parental rights are automatically terminated. So all of these things are agreed upon by all the parties involved, even though it's not really a contract, but it's as best as we can. Again, so the birth mother wants to give birth vaginally in the hospital delivery room unless her OB determines a C-section is medically necessary. The adoptive parents want to be notified as soon as possible when labor begins. They're going to be delivering at Navicent. The mother is going to have 2 hours of the baby after he is born, and if the baby is well. She agreed to pump and provide breast milk for as long as she's able to in the postpartum area, and then the baby will be bottle fed after that. And then they agreed to use email communication. Like, they were very detailed when they created this, so I thought it was very interesting. I actually have a friend who is on her second surrogacy pregnancy, so she's been involved with a lot of these at Navicent lately. So she has 2 of her own, and now she's on her second surrogacy with the same family. So she's kept in touch. No, no, they implanted and everything. It's all theirs. It's just her womb. But yeah. Oh. Just having babies again. No. All right. Now get your study guides open. Go to page 48. So I'm gonna use this as kind of a review of the rest of the stuff. So yes, the answers are in the back of the book, but don't look at them. Those are the numbers that don't. NA numbers, those ones. All the other ones on 48 and 49, only want to go through together. So number 3, a woman who is pregnant. A mama. The book says gravida. So the G, remember, so her pregnant. So if gravida is a person that is pregnant, what about a woman who has never been pregnant? Nulla gravida. Nulla, N-U-L-L-I, gravida. So also, if a woman has never completed a pregnancy beyond 20 weeks, what is the 20-week acronym letter associated with? Preterm. So P, so nulla para. Nullipara. So you don't necessarily need to memorize these terms, but if you see them out and about, these weren't discussed, and I want you to be able to recognize what these terms mean. So if nulla gravida means she's never been pregnant. For number 6, if it's her first time being pregnant, prima gravida. Prima. And if she has reached the 20-week mark, it is prima para for number 7. So again, like if you're at the clinical side and you're reading the doctor's notes and they're using these terms and you're like, I don't know what these mean. So I wanted to review some of these terms. So 7 is prima para. 8, if she's had has 2 or more pregnancies, so multigravida. So then the next one is multipara.
These are all spelled with no space, right?
No space. Yeah, it doesn't matter. You're not being counted off for spelling and grammar. Prima gravida or prima para, not both. So then the rest of them, you should be able to figure it out. So the capacity to live outside of the uterus. Viability. So there's no set weight or week. It's just roughly estimate, right? Who watched the Maggie and Milo story? So 11, if a pregnancy has reached the 20, but not completely to the 37 weeks, it's considered preterm. Just preterm. Yeah. So number 12, I don't know why it says 39, because it's 37 for full term. Yeah. Full term. So if the pregnancy goes beyond 42 weeks, what do you think that's called? Post-term. Post-term. Number 13. All right, what's the blood marker test for pregnancy? HCG. HGB is hemoglobin. HCG. Human chorionic, whatever hormone. Lowercase h and c and then big G, I think. That's the way I wrote it. All right, signs of pregnancy. So if the pregnancy related changes are only felt by the woman, presumptive. If it's felt by an examiner in 16, probable, but it's only positive when we have objective signs that we have seen the fetus. Positive. All right, number 18, irregular painless uterine contractions that can be felt through the abdominal wall soon after the 4th month of pregnancy. Braxton Hicks. So she can start feeling those contractions at 4 months. Kind of insane. Braxton Hicks. Skip on down to 21. What is this term for feeling the fetal movements? Yeah, fluttering or quickening. Number 22, if she's lying on her back and it compresses the abdominal blood vessels. Supine hypotension. Supine hypotension is not the same as orthostatic hypotension. Get that? So she can have both. Number 23, severe itching of the skin from accumulation of the bile. Anybody know that one? We're going to cover it a little bit more today. It's Pureitis Gravidarum. So like itching during pregnancy. Pureitis Gravidarum. Gravidarum. And then craving substances that are non-food. Pica, that can happen during pregnancy. Pica, pica, P-I-C-K, P-I-C-A. All right, now 25. Get through the rest of these terms. Again, what are subjective symptoms only reported by the woman? Presumptive. C. So when the fundal height has decreased from his last measurement, now the head is in the pelvis. What is that called? Lightning. So P. So the baby transitions back down. It's probably, hopefully, already turned at this point. And now we have urinary incontinence again and urinary urgency during the third trimester. So 27, the cervix and the vagina become a violet blue color. Chadwick's. Chadwick's, K. If she starts swelling in her ankles and the feet, but it's only at the end of the day. What? T for physiologic or dependent edema. When the cervical tip has softened, what is that called? Goodell's. So S. where was that? Lower uterine segment is soft and compressible. Agars. You. The fetal head rebounds with gentle upward tapping through the vagina. I think I mentioned the term in the lecture, but I did not describe what it was. That's why I wanted to do this one. My bad. Ballottement. Ballottement, J. All right, skip to 37. Hyperpigmentation of cheek, nose, forehead, a blotchy brownish color. That's the chlasma, or also known as melasma. So O. The pigmented line down the abdominal midline. Linea nigra. I. So cardiac output followed by reflex bradycardia because of the compression of vena cava. Again, is so this is the supine hypotension, which is called vena cava syndrome because it's compressing on the vena cava. So Q. And then number 41, skip it, go to 41. And so what's the lumbosacral curve lordosis? So M. And then skip to 44. And hemodilution that causes a low hematocrit and hemoglobin. Physiologic anemia. So H, which is what causes her iron deficiency anemia. Okay. Okay. Now let's try to do a DT. 42. One. How many were preterm? One. How many are not given birth to that are you're only full term at 37. So you would get G3, G1, L1. Marcia, 40 weeks. Birth of a child at 38 weeks gestation. How many pregnancies? How many of those were term? Those were preterm. 0. 2. Take it one letter at a time. Linda is experiencing her 4th pregnancy. First pregnancy, and it is live birth. The 3rd resulted in a live. How many times has she been? 4. How many of those pregnancies lasted to term? How many of those lasted to preterm? 1. Pregnancies, not babies. For A, 1. Now the living is where you count babies. 3. Got it? And number 7. Pregnant woman with obstetric history. Stillbirth.
But they got the wrong choice because the only one that's got a 0 for abortion is C. If she had an abortion, then
that category. So not or not B. So
and why would it be from? Why would it? Oh, that's 20 weeks.
Mhm. All right. Page 52. Do E. Tamara is concerned because she read in a book about pregnancy that her pregnant woman's position, or that a pregnant woman's position, could affect her circulation, especially to the baby. She asked what positions are good for her circulation now that she is pregnant. What if she's in her late second and third trimester with that supine hypotension on her side? Left is usually more comfortable. There's no contraindication to the right, but left is usually more comfortable. All right. Beth, a pregnant woman, calls to tell the nurse that she has a nosebleed this morning. Should she worry about it? Fullness in her ears. If it becomes persistent, I would be worried about it. But if it's just a one-time occurrence, you have that increased vasculature and congestion due to the pregnancy. So she's likely going to have a lot of nasal respiratory issues. The nasal congestion is normal. And due to the congestion and irritation, if, like my husband, whenever he gets a cold, he will get a nosebleed just because of the inflammation and issues in there. So not necessarily a red flag, but follow up later. So I would say not to worry about now, but if it continues, to call back. I wouldn't tell her to rush in here to come be seen. G, Karen is 7 months pregnant, works as a secretary full time. She asked if she should take a water pill that a friend gave her because she notices the ankles are swelling up.
No.
No, why? It's not her prescription. Could be dehydrated. Why would her ankles be swelling? So beyond the sodium and fluid issues, what's another concern in pregnancy? The hypertension. So we have to now follow up with questions for eclampsia. So what kind of questions would we ask? Headaches, visual changes, persistent headaches, irritability. Yeah, she's pregnant. And then if she was there and you could do an assessment, what would you do? Blood pressure. Protein in her urine. fitting? Is it just in her legs? Is it also in her hands, her face, neck? And then, her deep tendon reflexes. So H, third trimester, and she notices her posture has changed and experiencing low back pain. Is this normal? What's it called? Monica, who's 36 weeks pregnant with her first baby, calls the clinic and she felt some uterine contractions when she got out of bed. She confirms that they seem to have decreased in intensity and frequency since she has gotten up and walked around. What kind of labor? True labor or false labor? False labor. Let her know she's just fine. If it increases in frequency, duration, if she has any cervical changes or gush, those are true signs of labor, which we'll get more into next in the recording that I'm currently recording. All right, almost through with these, and then we'll go through some other things. All right. Yes. H was lordosis, and it's normal. So for chapter 8 on the next few pages, I'm going to do number 1, A, B, C, and then number 10. So 54. We're doing Nigel's rule. What's Nigel's rule? So her last menstrual period began on May 5th, 2016. We're going by the first day, remember? So don't care about the other one. May is 5, minus 3 is 2. So what month is that? February. 5 plus 7 is 12. So February 12th, what year? 2017. All right, Sarah had intercourse on February 4th. She's not had a menstruation period since the one that began on January 9th. Which date are you using? The period, not her time of menstruation, of intercourse. So what is January 1? So minus 3 from 1 would make what month? October. 19 plus 7, 26, in what year? 2017. So October 26th, 2017. Yeah, that baby's 3 years old, 4 years old. Do what? Oh yeah, so it should be 2016 still. Because you already went back the year. That was 2016. October 26th of 16. All right, C, Beth's last period began on July 4th. Don't care when it ended. Noted that her basal body temperature began to rise on, I don't care about that date either. So from July minus 3, April 4 plus 7, 11 in what year? Then number 10. Her LMP began on September 10th, 2016, using Nigel's rule. So 9 minus 3, June the 17th of 17. All right, turn to page 63. I think this one. So why does the mom need protein? She's creating tissues, right? She's also going to start producing milk. All of that is protein. She needs more protein because she's producing protein. So it's used for the synthesis of products, growth, and maternal tissues, and used for the expansion of blood and milk production. What are food sources? Meat, eggs, cheese, yogurts, legumes, nuts, grains. Yep. Also, what are legumes? Lentils. Oh wait. Burns. Hold on. Peanuts, black beans, chickpeas, green beans, lima beans, kidney beans, black-eyed peas, navy beans. Beans and peas. My husband hates when my southern comes out. All right, why does the mom need iron? It's cold. She is anemic. Remember why? Yeah. So we need the babies are vampires. Love it. All right, so we need iron for hemoglobin formation and fetal liver iron storage. So how do we get iron? Liver, meats, yep, spinach, whole grains, enriched breads. Yep. Legumes again. What are examples of dried fruits? Fruit that is dried. What is a fruit? Tomatoes? Tomatoes are fruits. It's a fruit. So, tomatoes are also citrus fruits from the exam last semester. Calcium. Why does she need calcium? Bones. She's building bones and teeth. How do we get calcium? Milk. Yep. Sardines. But specifically dark leafy vegetables, excluding spinach. Tofu, baked beans, and tortillas. Somehow or another, I don't know. That's what the book said. I know, right? And why does the mom need zinc? Nerves. So preventing congenital malformations, and it's also used for enzymes. So how do we get zinc? Pills. Specifically supplements, not just pills. So liver again, shellfish, meats, whole grains, and milk. Cooked fish, and then there was something about fish that you eat with bones that are still in it, and I'm just like, I eat everything without bones. Like, I don't know the difference in that kind of fish. Yeah, salmon does. So for zinc, used for enzyme systems and preventing congenital malformations. So page 69, number 3. Essentially, what is going on with the biophysical profile? What is it? 69. Yeah, what's the minimum score? 8. What is it looking at? It's still inside. That outside is apart. Inside, so it's moving, it's pretending to breathe. It's tone and the amount of fluid that it's in. So we'll give you your hydromenose status. So is it really invasive? No, it's just an ultrasound. It's a very long ultrasound though, because they have to count how many times the baby moves within 15 minutes and breathing. And if they don't catch them at the same time, it's different 15-minute increments. So it can be annoying. I've had them done. So this is what determined that I needed an urgent C-section was my biophysical profile. The night that I felt a little bit of a gush, but wasn't sure, I went in and was observed. Told some of y'all this story already. They did a biophysical profile and was like, you're at 8. We'll check you again in the morning. And in the morning I was sick, so I failed. And the reason that I failed was because my fluid was gone. And so then they took her because that was the risk for infection overnight, that my membranes had been ruptured already. So it can be a good indicator, not just of fluid status, but also of the baby's status. If they're moving around, they're active. If they're not getting a lot of fetal kicks when they're at home, even though they've done like cold water or orange juice, and they're still not kicking or moving much, they can do this to actually count how many times physically instead of feeling that they see the baby move. So yeah, they'll have to make sure that it's just the one that's moving. The number 4 is I was just wanting to use it as a talking point, not necessarily as a question and stuff. No, what you'll find is that this book that this is associated with is like nurse practitioner, doctorate level. So that's why I have it as a resource, not what you're reading out of. ATI is going to be your friend in this class, so you don't get overwhelmed. So start with my lectures and then ATI, and then if you really want to delve and go on a rabbit hole, you can go down this hole, but I'm not going with you. So I might not be able to answer all those questions. Just saying. I know just enough. So number 4 is talking about the RH. So, and genetic anomalies by getting an amniocentesis. So if she's negative, but her partner is positive, what's our risk? High. So she might get at least 1 dose, right? So preferably during that second trimester, she might get a second dose, but she's at least going to be screened and asked to get one. So the amniocentesis, what does that entail? What are they doing? Yep, they're taking a sample of the fluid, the amniotic fluid. The membranes have not ruptured. She is still pregnant. She's not in labor. This is percutaneous from the outside to the inside, takes a sample and sends it off. They can test the fluid for the congenital anomalies that may be present in the infant, because all of those cells came from the same stem cells, right? It all started from the same beginning. So that amniotic fluid is a byproduct of the fetus, technically. And so they can run some testing on it without having to interfere or then risk the baby. So then you have the cord where they can take a sample of the cord as well. Mhm.
Or would that be?
It's the doctor's responsibility. It's the nurse's responsibility to make sure that the patient understands it. And if there are any questions, you revert back to the doctor. If you've been in that area and you know and you can answer some of the simple questions, but you can't give any promises or statistics or anything like that, that's the doctor's knowledge preference. So there's a risk for infection from the site, and then there's a risk for the fluid, for the internal hole to the fluid now leaking out. So technically she has a rupture of membranes, but it's still internal. So it's more of a risk for bleeding and hemorrhage than infection in that case. Number 5, a non-stress test. What is a non-stress test? Melissa? You came and asked me a question before we started class about a non-stress test. Yes. So there's no stress being induced to the baby. That's why it's non-stress.
Right.
She is not being induced for any contractions. She's only hitting a button when she feels the baby moving. There's no stress on the baby. But just like with you and me, if I would get up to walk around, my heart rate should jump up a few. So should the baby's when it's moving. So that's all its timing, is that when the baby's moving, his heart rate is responding accordingly. But there's no stress induced on the baby. The contraction stress test is when we induce stress on the baby by performing contractions or inducing contractions. Remember the two ways? Pharmacologically, the medicine, oxytocin, and then the nipple stimulation, which also releases normal, regular oxytocin. So the non-stress, when she's just pressing the button and we're looking for the heart rate spike with movement, what is do we want it to be reactive or non-reactive? It should be reactive. Their heart rate should react to the movement. Ultrasound. And then the fetal monitor for the fetal heart rate. So the baby's heart rate is reacting to the baby moving, and that's normal. So reactive. A contraction stress test is when we're stressing them out, and then we have a positive or a negative. You want a negative. You don't want them to be stressed out. You want them to be able to tolerate the stress. Does that make sense? So if there's any concern about if the baby has issues with their cardiorespiratory system, they may want to induce stress before the actual laboring process to see what might entail with labor. And if the baby is already stressed out with just a few contractions, they'll revert to a C-section in order for the baby not to go into fetal distress by the end of delivery. So they're looking at that potential risk. Does that make more sense? Yeah, we already talked about occupancy. Okay. So some other complications, and that's spelled wrong. Anaphylactoid syndrome of pregnancy. What does that sound like? They're having an allergic reaction and they're pregnant. So what are signs and symptoms of an anaphylactic reaction? DIC, shock, ARDS, pulmonary edema, yeah. Hypoxia, yeah. Yeah, this should be released right at 4. What is this?
Bleeding clot.
So petechiae, it's a pinpoint clots underneath the skin. Why does this occur? The coagulation issue. So what risks might lead to this? Anybody that bleeds. They're all bleeding. They're all bleeding. So what are some of the bleeding issues that we've done in pregnancy? Placenta abruptio placentae. Placenta previa. What's the difference in those? Right. Which one has painful bleeding? Abrupto. Abrupto is the only one that's painful. Placenta previa and what is the other previa? Vasa previa are about the time of labor and delivery. And they're painless. The only pain they're having is due to laboring. Puerperal infection. So this is often called postpartum fever. So if there's any symptoms of a fever or tachycardia or any issues, they will hone down on sepsis on these mamas. And so there was a lot that was going on. A lot of things have broken. A lot of things have opened. There's a lot of risk for infection, right? So anything can get infected, really. But this is that term. Intra-Hepatic cholecystasis of pregnancy. What does intra-hepatic mean?
What is
Cholestasis. Chole, gallbladder.
inside living gallbladder?
So there's a duct between the gallbladder and the liver, and it gets blocked. So that buildup of bile causes a lot of itching. There's also other symptoms, just like with your cholecystitis, with pale stool, fatigue, right upper quadrant pain because of that liver. And so this was a concern of mine during my pregnancy because I started itching all over and got a rash. Yeah, ew. I was observed for 2 days while they had to figure out why I all of a sudden got a rash all over me. So was it anaphylactoid? Was it PUP? Or was it ICP? That's what they were trying to determine. They finally just said it was PUP, so pruritic urticarial papules and plaques of pregnancy. So it was just irritation of the skin. Nothing. Benadryl.
Why would you just
This is also due to a liver thing, but it's temporary, not a concern like this one. So this one can be concerning and lead to organ failure, but this one is just temporary. And once those the bile acids dissolve, you don't have any long-term effects. That's all my extra ones. Okay. I have your parking passes for Navicent. And then I figured the rest of the time I'd go over any questions or concerns about So.
Yeah.
It will be at 4. Yeah. If we get done before then, I'll release it before then, but that was just the end of the class. So. So everyone looked at or started their project.
No, you guys go home. Punch will start on it. Tomorrow.
I know.
Okay.
That's why we.
Oh.
of the document as well. That's APA format, so if you want to use it, pretty much it should be, I made it sure that it was a Word document so that you can update your stuff. Yep. Yep. And so then some of it may make sure that, because some ones have, some essays have like 4 problems, some essays have like 6 problems. So make sure you look at and use these headings. I even gave you the headings for each one. So then reset up the headings. Because I woke up super late today and y'all were anxious. So I didn't do my hair and also PPE. So yeah. Yeah. So. In ATI, yeah. We are done.